Okay, everybody, here's chapter 9 on shock. So what is shock? Well, it's decreased tissue perfusion that deprives the cells of oxygen and nutrients. Less energy is produced, and so the cells have to rely on anaerobic metabolism. Well, what is that? Well, that's the decreased amount of oxygen in the cells because they're deprived. And that causes a buildup of lactic acid, causing tissue acidosis and subsequent organ dysfunction. So the first type of shock is hypovolemic shock, where the circulating volume is decreased. Now that can be from a loss of blood or maybe dehydration, secondary to exercise, extreme temperatures, or some sort of trauma. Cardiogenic shock, the heart is weak and fails as a pump. Cardiac output is decreased, and that's usually seen in an MI. Then there's obstructive shock. That's where blood flow is reduced, entering or leaving the heart. So if you turn to table 9.1, it talks about different types of conductive shock, such as tension pneumothorax. That causes an increase in interthoracic pressure and compression of the vena cava. So it creates an obstruction. Cardiac tamponade, the fluid contents within the pericardial sac causing compression of the myocardium. Obstruction. Pulmonary embolism, a blockage of the pulmonary artery. So an obstruction of the blood flow. And then it also mentions abdominal compartment syndrome and superior vena cava syndrome. Then there's distributive shock, where the volume is intact, but because there's excessive dilation of the blood vessels, it causes decreased vascular resistance. For instance, let's look at a glass of water, a small glass of water, filled to the top with water. And then you pour that into an even larger glass of water. Same volume, but it doesn't look like as much because it's a larger container. The dilation of the container, I'll say, is like the excessive dilation of the blood vessels. So the volume is the same, but the dilation of the blood vessels causes decreased resistance. So it looks like you have less volume because the blood is not distributed evenly. And there's three things under distributive shock. One is anaphylactic shock, where there's a sudden and dramatic shock following exposure to a substance that causes a release of chemicals, and those chemicals dilate blood vessels and increase capillary permeability. Now, what is that? Well, capillary permeability is the seeping of the blood fluid into the tissues, into the capillaries. Then there's septic shock that can progress rapidly after severe infection. There's neurogenic shock, which is a disruption of sympathetic nerve impulses resulting in loss of vascular resistance or progressive hypotension. That progressive hypotension is very symptomatic of neurogenic shock, and this can occur during spinal cord injury. But basically, shock all lead to decreased tissue perfusion. So what are the effects of shock on the body, systems, and functions? Well, in the respiratory system, the respiratory system suffers from tissue hypoxia and anoxia. There's an acid-base balance because the lack of oxygen drives the cells to resort to anaerobic metabolism, which I had mentioned before, and that produces lactic acid. Lactic acid is not good. You can measure that in a lab test, but that does result in metabolic acidosis. Cardiovascular system, there's myocardial depression and decreased cardiac output. Then the neuroendocrine system can be affected. The release of catecholamines, mineralocorticoids, glucocorticoids, antidiuretic hormone, and decreased cerebral blood flow can all lead to shock and a vasodilation. Hematologic shock, where there's depletion of clotting factors like MODS, which is multi-organ dysfunction syndrome, peripheral ischemia, and the necrosis of digits. Then there's the immune system can be affected, where you have a decrease in immune response to something. GI system. The GI system reacts by decreased peristalsis. So the blood flow is decreased to the GI center, and there's decreased peristalsis. Everything slows down. Part of that decrease in aerobic metabolism. So decreased peristalsis, decreased bowel sounds, decreased blood flow to the gut. And also, there might be impaired liver function. Then the renal system can have inadequate renal perfusion. The stages of shock are pre-shock, which is like the initiation of shock, where there's a decrease of delivery of oxygen, and the body starts responding with vasoconstriction. Now, the body tries to prevent a problem. So the body reacts and vasoconstricts so that the blood pressure goes up. And if there's a volume loss, then the blood pressure won't drop because you vasoconstricted. Try to counteract whatever is happening in the body. If it's a decreased volume of blood or fluids. Then the next stage is shock. It's a compensatory stage. The baroreceptors that are located in your carotid arteries and your aorta stimulate sympathetic nervous system. So that sympathetic nervous system is sensitive to your needs. It increases your heart rate. It constricts the peripheral blood vessels, again, trying to increase the blood volume to the major organs. It does reduce blood flow to the kidneys because the renin-angiotensin system is initiated, and those are major vasoconstrictors. The adrenal cortex secretes aldosterone, which makes you retain sodium, and that's supposed to hold the water in. So again, you're trying to increase the volume in the blood system. The lungs try to compensate by rising the pH so that you breathe faster, trying to blow out that lactic acid and return to a normal pH. The skin, the decreased perfusion to the skin. So the skin to touch is cool. And again, the GI tract is slowed down. It suffers a lot because that's just one of the systems. You're not eating when you're in this state, or even when you're in a hunting for food state, sympathetic nervous system state, your GI gut is just slowed down. Then there's end organ dysfunction, and that's decompensated. You're deprived of oxygen. Anaerobic metabolism produces lactic acid, and the body goes into a state of metabolic acidosis. So the stages of shock, how does the patient respond to those stages? Well, in the pre-shock stage, the body starts getting a little tachycardic, some vasoconstriction just to keep that heart rate up. The skin gets cool and clammy, decreased blood flow to the peripheral tissues. The blood pressure is trying to stay normal. You get, again, tachycardia, decreased bowel sounds, guts, suffering. But at this point, it can be reversed. It can be reversed if you can stop the bleeding or if you can stop that hypovolemia. Next, patient response to shock is restlessness. So, whenever a patient gets restless, something's going on, especially if they're not normally restless. So restlessness is very important. It can be low oxygen. It can be that they're going into shock. So restlessness is very important. It's not just a time to sedate somebody or tie them into bed. Tachycardia again, respirations increase, blowing off that CO2, that acid, urine output decreases, the blood flow to the urine to the kidneys is decreased, the skin is cool and pale. And then end organ dysfunction, the patient response is confusion, or maybe even a loss of consciousness. They get hypotensive, their pulse is weak and thready. The respirations are still increasing though, because they're still trying to blow off that CO2 or acidosis. Their skin is cold, pale, and clammy. So the diagnosis is based on their history and physical exam. So what happened? Find out what happened to cause this. And physical exam, examine them. Tests and procedures that help establish the type of shock, stage, and cause. Blood and urine studies. I'm going to talk more about this, so I'm just going to go through this kind of quick. Blood and urine studies would be done, measurement of hemodynamic pressures, chest x-rays, EKGs, continuous cardiac monitoring, pulse oximetry, such a simple test, but we can tell so much with that pulse oximeter. Arterial blood gases, check their urine output. What color is their urine? How much urine are they putting out? So, first aid for shock outside the medical facility. So that is on box 9.1, if you could turn to that. I'd like to go through that. Focused assessment and intervention in first aid for the patient in shock. So first, their pulse, rapid and weak, very thready. Thready is an important word. It's even in quotes there. Respiration, their air hunger, increased rate of respirations. Then slowly it might get more shallow because it's not working. That increased respiration isn't helping them, and they get tired, and then their respirations get shallow. Their blood pressure, initially stable. Again, the body tries so hard to try to stay normal and try to maintain itself. So this blood pressure is stable at first, and then it might slowly decrease. The skin, because of the decreased perfusion, cold and moist at first. They might get diaphoretic. Then there might be cyanosis later because of that intense vasoconstriction, where they're shunting the blood to the major organs, the brain and the heart specifically. Cyanosis of the lips and nail beds may be seen. So cool and moist skin at first, and cyanosis of the lips and nail beds. Their mental status, restlessness, that could then get more listless. They might get confused, and then they might get unconscious as the stages go on. They might be thirsty because they're feeling dehydrated. So they're thirsty. Don't give them anything though, because they might have to go to surgery, or they might need IV fluids. So interventions, what are we going to do there? Well, we're going to summon medical assistance. If you're in a first aid outside of the medical facility, call for help. You're going to check their pulse and respirations and their mental status. Are they alert? Establish or maintain an airway. Really important, our ABCs. Control any bleeding with direct pressure or pressure dressing. One time I came upon an accident, I had to use my sweater as a pressure. But anything that's available, pressure is good in an emergency. Maintain blood flow to the brain. Now that could be if you have to elevate their feet to increase the blood flow to the brain. Now, that's not good if they're in cardiogenic shock, because increased fluid isn't necessarily good for the heart. But maintain the blood flow to the brain, keep the patient calm, prevent unnecessary movements. I know they're going to be restless, they want to thrash around, but try to keep them calm, because if the less they're moving around, the less oxygen their body needs. So keep their position flat. You can elevate their legs unless the shock is caused by heart failure. The head or neck, if the head or neck is bleeding, we don't want to elevate their head. Intracranial pressure is increased. We don't want to elevate their legs. Or the patient has dyspnea. Next, protect the patient from cold. You've seen those like aluminum looking blankets. So that's what the emergency people have. They have those aluminum foil looking blankets. Keep them warm. If all you have is a blanket, great. Keep them warm. Loss of heat will keep the body warm and keep things moving along. And prevent any unnecessary movement. Again, even if the patient complains of thirst, withhold oral fluids in case surgical intervention is needed. And tell the patient what actions are being taken. So take them step by step. Okay, now we're going to be moving you. Okay, now I'm going to lift your arm up. Okay, now we're going to start an IV. Whatever you do, be sure you talk to them. Talk them through what's happening, because knowledge is power, as I've said, and the patient goes for the patient as well. If they know what's happening, know what to expect, they're not as scared. Next is, let's try a question. So the type of shock that is caused by physical impairment is, I'll give you a second, see what you think. Hypovolemic, cardiogenic, obstructive, septic. Now think that through. It's really important in this chapter to think through each question. Physical impairment. So the answer here is C, obstructive, because something is obstructing. Some sort of impairment is happening. Types of shock include hypovolemic, which is inadequate circulating volume, so that's not it. Cardiogenic was decreased myocardial contractility. Well, that's not physical impairment. Obstructive is inadequate circulatory blood flow caused by a physical impairment. So that's pretty important to remember. And then, of course, sepsis would be from a massive infection. Question number 2. Which of the following is a true statement about the effects of shock on body systems and functions? So, are they in metabolic alkalosis? Is there increased glomerular filtration? Is there absorption of catecholamines and mineral corticoids? Or is there decreased peristalsis? Okay, I'm pretty sure that you probably guessed D, because I've talked about that a lot, the decreased blood flow to the gut. And as far as metabolic alkalosis, we're in metabolic acidosis at this point in shock. Increased glomerular filtration, well, it's decreased, and that's why we have the tensin, angiotensin, and we have the 1 and 2, we have the ADH. The absorption of catecholamines, we'll know because we're releasing those to try to help the body. So now let's go to general medical and nursing interventions for shock. So of course, number 1 is going to be oxygenation, where we maintain an airway so that tissue perfusion is a priority. Fluid replacement. So initially, until you know what kind of shock it is, just normal saline is good. After you determine the type of shock that it is, subsequent fluids would depend on that situation. So volume replacement continues until adequate perfusion. So they might do colloids, or there might be blood transfusions. Depends on what the problem is, what kind of fluid is received. Then there's some pharmacological therapy that's based on the management of cardiovascular situations. And if you could turn to table 9.3, I'd like to talk about those for a second. So table 9.3, it talks about dopamine as the first drug. And dopamine is good. We mentioned that before, I believe it was in cardiac, and it's good to increase the blood pressure. It's a vasopressor at high doses, but at low doses, it's good for renal perfusion or renal vasodilation. It's good for cardiogenic shock. The next drug under that is dobutamine. So the thing about dobutamine, it's similar to dopamine, but it increases the ionotrope, or in other words, it increases the contractions of the heart. So it's good for cardiogenic shock. Then an important drug here I want you to remember is norepinephrine. So norepinephrine is a vasopressor. It's probably the number one vasopressor that would be used. It increases peripheral vascular resistance, so it clamps down. That's one thing about some of these drugs is in order to increase the blood pressure, they've got to increase peripheral vascular resistance, which means that they're decreasing blood flow to the tissues in order to maintain a blood pressure. So it's good here for cardiogenic and myocardial infarction and sepsis. Epinephrine is a vasopressor, good for a bronchodilator, like if they're having some sort of breathing problems secondary to asthma, or maybe they've inhaled something they're allergic to. Nitroglycerin is a vasodilator. And then nitroprusside, very potent vasodilator. Vasopressin is a vasoconstrictor. I love medications that tell you what they do. So vasopressor, it presses the vaso system, the venous system, and it is a vasoconstrictor. So after that, I want to talk about mechanical management, which is on table 9.4. So I'd like you to turn to that. There's a couple of things that are important here, and that is the first one, the hypothermic device or thermosuit. So it circulates ice water in direct contact with the patient's skin, but it is a suit, so it's not, it's not like putting the person in a bathtub of ice water, but it slows things down. It may improve neurologic symptoms as well. So neurologic recovery after cardiac arrest. So important to remember that. Then also there's the intra-aortic balloon pump. I've seen a lot of those in the ICU, and they're usually, it's a balloon-tipped catheter that's inserted into the descending thoracic aorta, and the balloon inflates during diastole. So what that does is that it reduces the preload with cardiogenic shock. So it reduces the amount of fluid that goes into the heart. So when the heart pumps out, it's more adequate fluid. Then there's one more that I'd like to talk about, and that's the ventricular assist device. This is interesting because it decreases myocardial workload with oxygen demand. Some patients that are waiting for a heart transplant or are in congestive heart failure, they might need an extra kick, an assist device for the ventricle. So our ex-President Cheney had one of these ventricular assist devices for, I believe, about 20 months. So they can be worn for a long period of time, and he was awaiting a cardiac transplant. So the ventricular assist device is often seen, and people can walk around with that. They've devised it now so it's small and can be hidden. So on page 157 now, I want us to get us back on track to our page numbers because I know I had to move around a little bit. So page 157, we're going to talk about oxygenation. So remember, brain cells begin to die after 4 minutes without oxygen. So it is a priority, our ABCs, to maintain a patent airway. It is a priority. So supplemental oxygen can be given, so not only are you maintaining a patent airway, but you want to supply maybe supplemental oxygen. If it's a nasal cannula, that's fine. Maybe it requires mechanical ventilation, an oral airway. Monitor the respiratory rate, their pattern of breathing. Is it regular? Is it deep? Does both sides of the chest rise and fall evenly? What are the breath sounds? Listen to all lung fields. Do you hear air or do you hear crackles? And then you want to check their pulse oximetry. Are they getting enough oxygen? And that's a good way to tell. Then paralytics, sedatives, and analgesics may be ordered to decrease oxygen requirements. So if they had to paralyze the patient so they'd quit moving around, of course they need to be well ventilated if you did that. Sedate the patient so that they're relaxed, less oxygen demand. Analgesics, because pain takes a lot of stress, and stress requires oxygenation to the tissues, so those might be ordered. Next thing is fluid replacement. So fluid replacement, administer IV fluids as ordered. Usually, as I said, it starts out with normal saline. It just depends on the type of shock that it is. If it's a medication delivered by IV, they need an IV site for sure, but what goes into that site depends on the shock. Subsequent fluids may include various crystal colloids, plasma, other thickening agents for the fluid to increase the fluid volume. Just depend again on the situation. And then you have to watch the patient's response closely. How are they responding to this fluid replacement? Did we have a patient with a low fluid volume suddenly go into heart failure because you gave them too much fluid? So monitor that INO. Monitor the fluid going in very, very closely. Okay. Now, pharmacological therapy. Again, I believe I went through this already on table 9.3. It's based on manipulation of the cardiac dynamics, the contractility of the heart, the preload coming into the heart, the afterload, what goes out of the heart when the ventricles contract. What are they reading resistance? And then what is the heart rate? Are they still tachycardic? Or did the medication cause any of these problems? It's important to know that. That's why it's so important to know our medications. So no one drug will provide nutrients and oxygen to the cells. So several agents may be needed. So several IV sites. And it has to list to assist the 4 circulatory components. Now remember, norepinephrine is a great vasopressor. It has inotropic effect, increases the contractility of the heart, and increases peripheral vascular resistance. So what's that going to do? Increase the blood pressure, increase the output of the heart. Mechanical management. So I guess we already talked about these when I went over the mechanical part, but let's talk about it again. So management of shock, because we need to hear things a couple times, right? So the hypothermic device, sometimes we call it a mask suit, that circulates ice water. Sometimes it's just pressure, pressure on different parts of the body. So I've seen mask suit garments where it rotates, constriction, different parts of the body, and that helps maintain fluid volume. Intra-aortic balloon pump, which reduces preload, and there's a picture in your book, and I believe I have a picture on the next page of that. Then the ventricular assist device, which is important to help someone get from congestive heart failure, or assist them while their heart is repairing, maybe after an MI, or it could also be worn while you're waiting for a heart transplant. So here is that picture of the intra-aortic balloon pump, and you can see it's actually a balloon that inflates, and by inflating it decreases the amount of fluid that's ejected, and it's inflated during diastole, so it takes up the space and there's less fluid that's ejected from the heart. But it seems adequate enough because that balloon has taken up room. So nursing care of patients with shock, what do you need to do? Well, you need to do a focused assessment. Very close check on these patients. Monitor their blood pressure, their heart rate. Is it regular, irregular? Is it slow? Is it fast? How's their temperature? Is it rising? What's their respirations and the movement of their chest? Check the abdomen for distension, tenderness. Palpate the bladder and check the urine output. Now the urine output that you need to watch for is 0.5 milliliters per kilogram per hour. So keep an eye on that urine output and remember that 0.5 milligrams per kilogram per hour. The reason we would palpate the abdomen for distension is maybe they're bleeding internally, so we can't see that. So that's why we're monitoring and keeping close evaluations, close tabs on their vital signs. Any patient problems, inadequate peripheral circulation, inadequate cardiac output, are they confused? Are they in a fluid volume deficit? Is their urine output dropped? Are they anxious, restless? So some interventions that we would do would be inadequate peripheral circulation. Now this is in your nursing diagnosis. Inadequate cardiac output. So inadequate peripheral circulation, let me just go back to that. Pulses, temperature of their skin, O2 saturation, because that will change if they're not getting good perfusion to their fingers, right? Check the color of their fingers. Are they cyanotic? Are they normal? Are they warm? Are they cold? Inadequate cardiac output and risk for impaired cardiovascular function. So IV fluids. Monitor their IV fluids. Administer inotropic, contraction, antidysrhythmic if they go into a dysrhythmia, especially if it's cardiac shock. Vasopressors, keep that blood pressure up so that we can keep the brain and heart perfused enough oxygen to those major organs. Are they confused or anxious? Manage their pain and anxiety because that will reduce their oxygen demands. The more they thrash around, move around, get nervous, they're increasing their oxygen demands, and we just don't have that much to give right now until we fix the problem. Protect them from injury. There's going to be a lot of noise, a lot of lights, a lot of movement. They've got IV sites that have to be watched, and that's also under potential for injury. IV sites that need to be watched. If there's drugs infusing in there, these are very heavy drugs, so we have to keep an eye on those sites. And if the patient's thrashing around, that IV could get disconnected, or infiltrate. Fluid volume deficit, so notify the physician, here it is again, if the urine output falls below 0.5 milliliters per kilogram per hour. So low urine output may indicate inadequate fluid replacement or renal failure. So hopefully at this point, they're in a place where you can check blood values, their creatinine, their BUN, see what their lab values are. You can determine if it is just a low urine output due to lack of fluid or renal failure. Has the shock reached their kidneys, kidney perfusion? There's a potential for injury, so observe their IV sites, any adverse side effects of these drugs. Watch for pressure injuries, because so we want to decrease the amount of oxygen demand that the patient is using up. So we want to keep them in one position. Well, that could cause a pressure injury if we keep them on their back all the time. Potential for infection. Now, these patients probably have IV, maybe multiple IVs, a Foley catheter, maybe chest tube, airways, maybe they're on a ventilator. So they have many things going into their body. Whenever that happens, they're at risk for infection. Inadequate family coping. So I believe there's a cultural consideration box that we need to look at. So keep in mind, everyone views shock differently. Some don't understand what it is. So when a patient is critically ill, family expectations and behavior may be influenced by their culture. For example, some families expect to participate in patient care. They want to help, or to remain at the bedside. They don't want to leave their patient, but sometimes that gets in your way. Extended families may gather to be near the patient and to comfort one another. In some cultures, important decisions may be deferred to male relatives. Culturally based rituals related to illness and death may be very important to the patient and family, so we always have to keep that under consideration. All right, so another thing that we might encompass is systemic inflammatory response syndrome, or SIRS. So this is a generalized inflammation that threatens the vital organs. It's inflammation, usually due to stress. There's a 40% mortality rate if they get this. Conditions that lead to SIRS are shock, multiple transfusions, massive tissue injuries, burns, and pancreatitis. Effects are damage to the endothelium of blood vessels and a hypermetabolic state. So that damage to the endothelium sets up that inflammatory response. Diagnosis, it's inflammatory. It is not infectious. So antibiotics are not going to help this. Medical treatment and nursing care minimize the physical demands on the patient with drugs and sedatives. Support their failing organs. As you can tell, this is a last stage that they might go through. Support failing organs with vasopressors, other medications, blood, plasma, and respiratory support. They might need to be on a ventilator to give them the proper oxygenation, and of course they may need to be sedated to be on that ventilator. And because they're sedated and they're not getting any food or energy, they might need enteral feedings. So this might be an NG tube rather than a G tube, because it might be temporary, hopefully. So an NG tube put down, and they're given feedings through that NG tube.